Thank you, David, Dan, and Pauline, for inviting me to speak at this occasion, Cambridge, Africa. I was just beginning when it was born, and I'm really happy to see how far it has come. Cambridge was a very different place without it. And thank you very much. So as I've been introduced, I'm really a frontline worker in the field of maternal health, working at Makerere University, which is housed in Mulago Hospital, Uganda's National Referral Hospital at the same time. And I'm not sure everybody knows Uganda, but without taking you for granted, I'll just say a few things about Uganda. They always say it's the size of Great Britain, and we have about 40 million people now, and it's one of the countries with the highest growth rate in the world, over 3.4%. Of course, that is good and also at the same time bad, but we're happy to say that the life expectancy of Ugandans has really increased dramatically over the years. Previously, Uganda was known for probably very wrong reasons. I remember even when I came here in 2009, people were still asking me about Idi Amin. And I remember saying, you see, Idi Amin died a long time ago, and I only remember I was born during his era. So, much as we've had a lot of improvements in health, especially maternal health as a country, there's still a lot that needs to be done, with the maternal mortality rates remaining unacceptably high. Of course, if you can see, for some time the rates were really remaining the same. And then about 10 years ago, we kind of got a boost and there was some reduction, but we were disappointed if 5 years later to go back a bit higher. I mean, we know that this is a real problem because this is actually an underestimate, knowing that we have a lot of deliveries occurring outside the health facilities. So a lot of death and birth go unregistered. So for us to see that we are kind of stagnant at that figure, we really have good reasons to worry. We've improved in terms of the number of deliveries which are occurring under a skilled birth attendant. However, as you see, 57 is still not good enough. We have another 43% of women still delivering out there, and we don't really know whatever happens to them. So Mulago Hospital, I think Ashley has really told you enough for today, but just remind you that it is a very, very busy hospital, now recognized as the busiest maternity hospital. And interestingly, this was a gift to the Ugandan people by the British government at the time of independence in 1962. So it is, you compare the population of Uganda then and now, and there's not been any other big hospital built. So it's really doing a lot of work, and this comes with challenges as expected. We have about 100 deliveries a day. Now, what that means that anytime you walk into our labor ward, about 2 babies or 3 are being born, either by cesarean or normal delivery. And we still have a relatively high cesarean section rates, but I want to tell you now that 25% people consider high, but we have a lot of women who still don't get the cesarean section done in time, and that comes with very poor consequences. So this unmet need for cesarean section is partly contributing to the high maternal mortality we still see. And despite a relatively good antenatal attendance, and our antenatal clinics are really busy. We have about 200 new mothers on each antenatal day, which is a Monday to Friday. So it is a beehive of activity as far as maternity care is concerned, but we still have a lot of bad outcomes. And just remind you that still these are the major killers of women in our setting. And I put pre-eclampsia and obstructed labor in red because there's something very special about them. Obstructed labor, it is something really now not heard of outside Africa. because we know that if a woman is in labor, she should be monitored, and you should be able to know early enough that she won't make it and give her a timely cesarean section. But this is a luxury we cannot afford in many parts of Africa. And in fact, obstructed labor is one of the big chapters we're trying to write about in our African textbook of obstetrics, because it's nowhere else in the Western textbooks that we read. My favorite textbook is William's textbook of obstetrics, but you can never find a chapter on obstructed labor. So in a way, it means that there are a lot of African problems that we can't read about, we can't really talk about with authority because there's nothing known about them. But pre-eclampsia, of course, remains the #1 non-preventable cause of maternal mortality and morbidity, and not only in Africa, but globally. And why I stress that is because we may think it's an African problem, yes, but understanding it in Africa is likely to really drive the understanding elsewhere. And I'm really convinced that the reason why for a long time we don't understand a lot about pre-eclampsia is because we've been looking in the wrong places. We've not been looking where the patients are. And so now that we're beginning to look where we should, I'm sure in a few years' time we should have a lot of unanswered questions really answered. And just to emphasize that my fascination with pre-eclampsia is because as a young doctor, I realized very early that this disease was really a major killer, and a lot of attention was being paid to hemorrhage, sepsis, and other things. And we knew what to do with these complications of pregnancy, but probably resources were not allowing us to. However, pre-eclampsia was really unknown, a lot was unknown, and I felt like if I don't do something about it. At that time I was also a young mother myself, and in fact I had survived the disease on more than one occasion. So I felt like us sitting back and just saying this is a disease of theories, the cause is unknown, common cause of death in Africans was not enough. Actually, at one time as a young obstetrician, I told a colleague that when we sit here and just treat the patients, I feel like we are accomplices in this war of sorts. So you remember people say we shall not remember the words of our enemies, but the silence of our friends. And I felt we at the front line were the right people to really drive this agenda of trying to find why are African women dying of this. And I believe that this story of it is socioeconomic status was not enough to explain this level of morbidity we were experiencing. And I was really convinced there was something really biological that was driving this. And so when I got the Wellcome Trust PhD fellowship, and which gave me an opportunity to work either with scientists in Cambridge or London School, and as you heard, I tried to Google up and find out who was doing work in pre-eclampsia, and I found it was Ashley Moffett. I was really excited, but I had never been to Britain. I didn't know who Ashley Moffett was, but I was just a simple, young, excited African obstetrician. So I came to Cambridge with not sure what really to expect, but I had this inner hope that I was really going to find big things. And I'm really happy that many years down the road, I'm telling this story with a lot of passion and happy that I came. So this is my very first visit to Cambridge in the spring of 2009. Lydia over there was really my coach in trying to do this work. Remember, I was coming from a very clinical background. Now I had ventured into the unknown world of the lab, trying to understand a condition really which is unknown, moreover most unknown in Africa. So it was kind of a very high-risk project, but the determination I had to answer these unanswered questions kept my hope alive. And in summary, we went on to recruit the participants from Mulago Hospital, and this was not difficult as you heard about the numbers. And when we got the mothers, we extracted the DNA from Uganda, and then the samples had to be shipped to Cambridge, where the downstream lab work was done. I kept making back and forth movements here to learn and to do the typing, as expected of a PhD student. But along the way, it's always said that pre-eclampsia is a disease of people of African ancestry. So I remember actually asking me, but Annette, where is this? Where do you find this? How sure are you? I told her, anecdotally, I can say so, but you see, I needed to compare. Most women are dying of this in the African continent, and everybody says it. Though when they say it, I sense that they meant mainly African Americans. And we know African Americans are not really the indigenous Africans. There are a lot of differences genetically. So as part of this project, we wrote this review to try and understand really why do people think pre-eclampsia is a disease of people of African ancestry. But interestingly, we also came about, we confirmed what we thought, as Ashley said, that this was common among Africans everywhere, whether on the African continent or elsewhere. But in addition, there were also many other interesting differences to do with pregnancy and nutrition between Africans and other non-African ethnicities. And I felt like really I was the right person to point this out in a nice way, not in a stigmatizing way, because I think if we understand really what these differences are, then we'll appreciate them and be able to really get to the root cause of many of the problems that Africans are facing. So one of the interesting findings that it seems like consistent that the gestational age for Africans is really less than for the non-Africans. And this should be an advantage in that it means the babies are ready to come out earlier, and that would mean they mature faster, so that when they come out, they are ready to survive. And we suspect this is because of probably the differences that have been shown to exist in the pelvises of Africans and non-Africans. And could be one of the problems why we have a lot of obstructed labor. Well, that was what we thought then, and I'm sure we've gone on to think that this is something really we need to look at critically. But one of the major findings is that the kind of pre-eclampsia we have on the African continent is very severe and many times recurrent and tends to occur at a very early gestational age. So with those differences in mind, we went on with the rest of our work. And one of the major findings of our project was a study that was recently, about 1 year ago, published in PNS. And this was one showing that there is a particular genetic variant which seems to protect African women against pre-eclampsia. And this is different from what is protecting the European ones that Ashley had found earlier in the Caucasians studied here. So what was also interesting about this is that a few years earlier, you can see this, well, it's not really, I think it's not coming out clearly, but we found that this was really a genetic variant that had been described to occur only in people of sub-Saharan Africa. So the question was then, why would it be the case? And this was not unprecedented, because we know, for example, malaria, there are various genetic variants that affect hemoglobin that are known to protect people against malaria in different settings. So this seems to be the same situation we are faced with as far as pre-eclampsia is concerned. And also as part of this work, we were able to describe the immune system genes, the key immune system gene frequencies. In that time, what was the biggest African study? Most of the studies before this, first of all, were few, but they had very small numbers. And ours was close to 500. And we were able to see very glaring differences, interesting differences between the key immune system genes and between the Africans and the non-Africans. And of course, the genetic diversity itself was very obvious. And this gave us the belief that the more we looked at the care and preeclampsia in the African, the quicker we were likely to find answers to what really causes preeclampsia. And also what was interesting is that we were able to see that this brown region here and here, the risk paternal alleles that had been identified in the fetus occurred with high frequency in Africa and of course in the native Australians. And this was very interesting, but also we were thinking that probably this could explain why we have very high prevalence of preeclampsia among Africans. Of course, the presence of these alleles must be for some reason. Probably they are protecting against some of the very old infections on the continent, and usually malaria is one of the first suspected culprits. So briefly, I would like to say something about why I think this has been a very successful collaboration. There's been very good supervision and mentorship, with Ashley always checking on me, and if she senses I'm not coming to Cambridge very soon, she plans a visit to Uganda. I mean, with time I got used to the frequent visits, and whenever she came, she left behind me boosted and feeling like, yes, I am doing it, I'm making it. Ashley was here. And when I would come here, I would go back with more ideas. So that close partnership with South-North, I think really made it work. And of course, the set of the labs and teaching facilities here at Cambridge. Because when I started out, things were not really easy in Uganda. There were very few good labs. But towards the end, I mean, with more money injected into research and other funding coming on board, I could see that I could do a lot of things back home, but that was not the case in the beginning. And so we don't really take these things for granted, but they came out of this kind of partnership, and Cambridge Africa is very much part of this. And of course, the large numbers of high-risk pregnancies. I mean, there I am lamenting about the high numbers, but I think we always need to turn challenges into opportunities. So we've been able to recruit a large cohort of pre-eclamptics over a relatively short time, and this has been a good resource in helping us to understand quickly what could be causing preeclampsia, and also especially among Africans. And there's ongoing work. I mean, this could have been PhD born and then that all ends. But there's a lot of work which is ongoing, as Ashley has pointed out. But we are continuing with increasing on the size of our cohort. And we're also looking at other things which have similar pathogenesis to preeclampsia, like unexplained stillbirth, fetal growth restriction. And at the same time, we are also trying to do things that kind of like can be immediately translated into clinical practice. Like following up this cohort of women with preeclampsia to try and assess who the cardiovascular disease risk that they're already carrying. And this is mainly important because, as you're aware, much as we still have a lot of infectious disease burden on the continent, the non-communicable diseases are almost taking over. So we are in a catch-22 with still having to address the problems of infections, but the non-communicable diseases are already on board. And so we are trying to follow up these women to try and assess those and be able to diagnose them early in case they have chronic hypertension and other cardiovascular diseases, so that we are able to reduce the severe morbidity from preeclampsia, as it's now known that actually preeclampsia is a marker of future cardiovascular disease. Also, malaria is on board, and I've been mentored enough to now take on a PhD student who is studying these same immune system genes. in placental malaria and also childhood malaria. And Ashley is on the side cheering me on as I also take on this role of a mentor. So there are a lot of opportunities for research on the continent, and in particular at Mulago. This hospital I've been talking about, which was a nice gift 54 years ago, has done its work. So we are coming up with a new women's hospital, which should be up and running in the next 1 year. And with it is coming a more elaborate referral system to try and decongest and be able to offer quality care to the women without having to have them all in one hospital. So for those of you who are planning to visit, the next time you come, you may find us with a new women's hospital just close to where the old one was. And I think this also gives us an opportunity to do multi-center research. It doesn't take away the opportunity of having high-risk pregnancies. Instead, it makes us be able to provide good clinical care, but at the same time continue with the research as we've been doing. And of course, this is one of the excitements about this whole collaboration with Ashley, is that it's moved from just being research links to clinical links, because as you see, we're doing interesting work, it's elegant, but there's no immediate benefit for our participants. So we believe by doing things that we can do at the moment, like improving the diagnosis and care given to women, pregnant women, especially those with pre-eclampsia, we'll be able to at least reduce the morbidity and mortality. At the same time, we try to find the cause, which hopefully will come through in the next future, in the next few years. And I'm really happy to pass on the baton now to Catherine. Oh, she's here, who is kind of my twin, working with her via the clinical links and actually continuing on with the research links. So Catherine, you're welcome. Thank you for listening.